So, good afternoon, everyone, and welcome back to the session. Post lunch, to be alive without sleep is the most. అది ఎటో పోతుంది ఇక్కడ పెట్టండి. లేకపోతే అక్కడ పెట్టండి, అక్కడ పెడితే అందరికి వస్తుంది. ఓకే. Post lunch, to not sleep but attend is one of the challenges. So, antiplatelet and antithrombolytic therapy. As a neurologist, what is the most important decision you will take tomorrow? Shall I or shall I not give aspirin? Shall I or shall I not thrombolyze this case of stroke? Most important decision. That's the reason whenever any patient has got a neurological paralysis, what is the first important investigation whenever a hemiplegic patient presents to you? Non-contrast CT. By in non-contrast CT, if there is any bleeding, you can identify. If there is no bleeding, you are able to see infarct, then you can at least start thrombolytic therapy. Correct? So that is the reason the most important aspect of the clinical management of hemiplegia is to decide on platelet therapy and thrombolytic therapy. So what are the various thrombolytic we use? Intravenous. Typically, what is the golden period during which you can give the thrombolytic therapy after the onset of the neurological deficit in stroke patients? 3 to 4.5 hours. Already patient is on aspirin therapy and he got stroke. Then aspirin plus dipyridamole, it's called double antiplatelet therapy. Dipyridamole and aspirin or clopidogrel, either dipyridamole, pyrimidol or clopidogrel along with aspirin is given. Suppose you have a stroke patient who has atrial fibrillation. Commonly, what is the cause of a hemorrhagic stroke, doctor? It is a thromboembolism coming from the heart is responsible for a hemorrhagic stroke. So, typically, whenever the stroke with atrial fibrillation, if it is there, that means it's a thrombus, then you need to go for long-term anticoagulation. Because unless you treat the underlying clot and prevent the new clot formation, continuous showering of the thrombi to the brain lead to continuing strokes. That's the reason you need to give warfarin, dabigatran, rivaroxaban. They're all the modern antithrombotic agents. So you should know three things, doctor. One is antiplatelet, thrombolytic, and antithrombotic. They three are different. Heparin, what is that? It is a antithrombotic. Streptokinase, urokinase, alteplase, they are all thrombolytic. That is already existent clot, they will break. Agreed? So, whenever there is any, so all these drugs, warfarin, dabigatran, rivaroxaban, they're all examples of what? Antithrombotic agents. And what is the speciality of dabigatran? What is heparin? Antithrombotic agent. How does heparin function? Heparin will go and cause activation of antithrombin. Antithrombin in turn will come and cause inactivation of thrombin. What is thrombin? Thrombin is formed from prothrombin. What is prothrombin? Factor 2 is prothrombin. So it will, antithrombin which is inactive, it will make it active. Antithrombin will come and inactivate the factor 2. That is the reason heparin is called indirect thrombin, antithrombin, not a direct antithrombin. There are some direct antithrombin agents. They include the bigatrin, rivaroxaban, etc., etc. They directly go and attack the thrombin. The factor 2 is what you need to remember. So whenever there is any stroke with a large anterior circulation, artery occlusion, and patient came within 24 hours of symptom, then that is an indication for mechanical thrombectomy. What is mechanical thrombectomy? Interventional radiologists, what they do? They pass the catheter, directly reach the area where the thrombus is there. There they will directly instill the alteplase into the thrombus and break it down. That is called mechanical thrombectomy, and then you need to treat them with aspirin. The next clinical scenario, you have a patient with intracranial large artery atherosclerosis. Then you need to give aspirin plus clopidogrel for 90 days and then only aspirin. So each of these protocols of clinical management which are evidence-based, you need to have in tips. They give in various forms of MCQs of different combination of clinical scenarios, right? So this is the rivaroxaban, dabigatran, alteplase injection, because if you really see injection, you'll get conviction. Now, doctor, you need to know a little bit about circle of Willis anatomy before we go forward in the topic of stroke. Internal carotid artery, tells kada? External carotid, internal carotid formed from common carotid. External carotid give 0 branches. Internal carotid give 0 branches in the neck, but external carotid will give ascending pharyngeal artery, middle meningeal, all these branches. Internal carotid, after entering into calvarium, will give rise to ophthalmic artery. Then from the internal carotid arise the middle cerebral artery first. Agreed? You can see middle cerebral artery. From middle cerebral artery arise the anterior cerebral artery. Anterior cerebral artery arise from the middle cerebral artery. In the posterior aspect, if you take, the 2 vertebral arteries combine to form basilar artery. Basilar artery divides into posterior cerebral artery. Between posterior cerebral artery and internal carotid, it is called posterior communicating artery. Then from the internal carotid artery arise the middle cerebral artery and also anterior cerebral artery. Both of them are originating from internal carotid artery. Between the 2 anterior cerebral arteries, you have the anterior communicating artery. This is how the posterior circulation is, and the anterior circle of Willis. From the basilar artery, if you look at the midbrain, pons, medulla, the basilar artery stands like a vascular tree behind it. So that is the reason basilar artery occlusion is very dangerous, because that will affect the brainstem. Which cranial nerve nuclei are there in brainstem? In the brainstem, in the midbrain, you have 3rd and 4th. Pons, 5th, 6th, 7th. Medulla, 9th, 10th, 8th, everything else in medulla. Once more tell me, what do you have in midbrain? 3, 4. Pons, 5, 6, 7. Everything else in medulla. And all of them are supplied by basilar artery. Also, there is a branch called Pica, posterior inferior cerebellar artery, which supplies the lateral aspect of medulla, only lateral aspect of medulla. Then you have ICA, anterior inferior cerebellar artery, which arises from sometimes basilar artery, sometimes vertebral artery. All right. So this is the typical structure you need to know. Once more summarize. Vertebral artery is combined to form basilar artery. Basilar artery divides into posterior cerebral artery. This is posterior circulation. Whereas dental carotid gives rise to middle and anterior. Two anterior come to by anterior communicating artery. Middle cerebral artery gives rise to many branches called lenticulostriate branches, which supply internal capsule, thalamus, and all these areas. Now, whenever middle cerebral artery stroke is there, what will happen? Whenever middle cerebral artery stroke is there is a contralateral paralysis and sensory loss. My right middle cerebral artery will make me to get contralateral side paralysis, sensory loss, both in the face and also in the arm. The gauge, the eye, lateral gauge is there, no? Left, right, lateral gauge. Up, down, it is vertical gauge. The gauge will go into a deviation and it will be looking towards my lesion. Suppose my right middle cerebral artery is occluded, the patient's eye will be looking towards the right side. It will be gauge preference will be towards the side of the lesion. There is a homonymous hemianopsia, in the visual defects. Suppose if the non-dominant hemisphere, right-sided people, left hemisphere is dominant, right is non-dominant. If that right, in a right-handed guy, if a right middle cerebral artery is affected, then they get hemi-neglect. Half of the body, they don't know that they are wearing shirt. Only one half of the body, they wear the shirt. Suppose if the dominant hemisphere is involved, that means the right cerebral artery occlusion, if the right-handed guy, if the left cerebral artery is affected, then they develop aphasia. That is, difficulty to speech, problems will come, no, paralytic patients. That all occur whenever the dominant hemisphere is involved. Neglect is a feature of non-dominant hemisphere is what you need to remember. So please know, contralateral motor and sensory impairment mainly in the face and upper limb. Eye deviation towards the side of infarct. Homonymous hemianopsia. Aphasia if it is dominant, neglect if it is non-dominant. Please don't forget middle cerebral artery. Middle cerebral artery has got one superior division, one inferior division. Whenever the superior division is involved, I'm talking about the left side. Left means right-sided people, dominant part. If the superior division is involved, there is a right-sided motor deficit. Face is involved. Arm is involved more than the leg. Arm more than the leg. Broca's aphasia. What is meant by Broca's aphasia? There are two areas for our speech. One, to synthesize the speech. It is there in the inferior frontal lobe. It's called Broca's area. Other is in the temporal lobe, which is called Wernicke's area. Wernicke is to have comprehension, to understand. Broca's is to speak, to create speech. Understand? Who is more depressed guy? Wernicke or Broca's? Broca's guy understands, but can't tell. It's like a boyfriend who admires, loves, adores, but can't tell I love you. It's okay. If a right girl comes, he will tell I love you. Currently, he don't have guts to say I love you to me, but to some other girl. Whereas Varniki, he don't understand whether the girl is saying I love you or not. He is more depressed. Does she love me? Does she not love me? She is thinking to tie a Rakhi or what? He is not sure. Who is more depressed? Varniki is more depressed. Right? Broca's is called motor aphasia. Motor aphasia. Varniki is called sensory aphasia because they can't comprehend. So, if you don't know how you feel about the other person, what will you tell? Suppose a Varniki is patient, you ask. What you are asking, he didn't understand, but he knows something you are asking because his eyes are seeing you moving mouth. Then he will try to answer without knowing the question. So you asked, what is this? He'll say, so what is he saying? He is saying jargon, but he is not exactly saying what that is. It is a pen. Whereas Broca's guy, when you show and say, what is this? He understood what is this is the question you are asking. So what will he say? Pen. But he can't say pen directly. He'll say, that's what he will say. Understand? So that is called agrammatical motor aphasia, which is Broca's, because he doesn't know how to form a syntax. Grammar is missing. But he knows pen is pen, car is car, orange is orange, wife is wife, and girlfriend is girlfriend. He is very sure. Whereas the Wernicke's guy has a difficulty to comprehend. Hence called jargon aphasia is the name given to Wernicke's aphasia, is what you need to remember. So tell me, doctor, quickly, where is the Broca's area located? Fatafat. Loud. Infra. Temporal, frontal. Frontal, Broca's, temporal, Wernicke. Malayapani. Frontal, Broca's, temporal, Wernicke. అర్థమైందా? ఎప్పుడైనా మనం క్లాస్ వింటుంటే గుర్తుపెట్టుకోవడం ధ్యేయం కాదు, అసలు ఇది ఒక పదార్థం ఉంది అని తెలుసుకోవడం ధ్యేయం. ఓ, there is a Broca, there is a Wernicke, which lobe they are there, we should know. That is what you should know. Lot of people have a wrong technique of learning. What is that? They open the book, underline, or form the notes. They are just reproducing what is there in this, in that, and after that they will forget what even they have written. So the best way to learn is what? When you read Davidson or any book, divide that into questions. Okay, Parkinson, what will be the symptoms? Parkinson's, how do I treat? Parkinson's, what are the important differential diagnoses? So convert what you read into a set of questions. And next time, throwing away the book, sit with a friend and, అరే పార్కిన్సన్లో ఏముంటాయో ఒక 3 ఉంటాయో 4 ఉంటాయో చెప్పరా అంటే, రిజిడిటీ, ఎకినేసియా, ట్రెమర్, గురు. He told you 3 symptoms. Very good. Why there is rigidity, re? Anna, Parkinsonism extra pyramidal, re. That's the reason there is a rigidity, because pyramidal tract will lead to spasticity. Like that, you Yaksha Kinnara Samvada, it is called. Yaksha was asking questions, right? So if you break what the material you are going to read into a set of questions and can reproduce by repeatedly asking yourself those set of questions, that's the fastest way to learn. Not a dot of ink you need to blot on the book. Okay? So superior division is what? In left side, dominant MCA, motor deficit, face involvement, arm more than leg, Broca's. Inferior division, temporal lobe is involved. That is Wernicke. Wernicke's aphasia, homonymous hemianopia, and right sensory loss, because it is a left MCA. Right MCA, superior division, it lead to motor deficit. No aphasia in. Is there any aphasia in non-dominant hemisphere? ఇప్పుడే చెప్తున్నాం కదా, ఎఫేసియా దేంట్లో ఉంటుంది? డామినెంట్లో నాన్ డామినెంట్ హెమిస్ఫిరిక్ ఇన్వాల్వ్మెంటా? డామినెంట్. అండ్ నాన్ డామినెంట్లో ఏముంటుంది? హెమీ నెగ్లెక్ట్. వినరా? రెండిట్లో ఏముంటుంది? హెమిప్లేజియా. Hemiplegia, homonymous hemianopia is a common thing, whether dominant or non-dominant MCA is involved. But what is speciality? If the dominant MCA is involved, you additionally have aphasia. If it is the superior division, Broca's. If it is the inferior division, Wernicke aphasia. Clear? But if the non-dominant hemispheric involvement, what do you have? Hemi-neglect is what you need to remember. So what is meant by Gerstmann syndrome? Mundu peru cheppandi, em syndrome? Loud. Gerstmann syndrome. There is no difference between me and a primary school teacher. Ultimately, MBBS ayinaka Parkinson, Wolf Parkinson, వేరు చెప్తే గ్రేట్, చాలు. సో ఇద్దరు ఒకటైనా, రెండు ఒకటే సిండ్రోమ్లా, దీని ముందు వుల్ఫ్ ఉన్నది, దాని ముందు లేదు, అంతే కాదు కదా. Gerstmann చెప్పండి. ఫింగర్ ఎగ్నోసియా. There is the inability to name their own fingers, affecting both the sides. Difficulty to name their own fingers. Finger agnosia. Right left confusion. Acaliclia, they can't calculate. Agraphia, inability to write spontaneously. These four combination is called Gerstmann. What are the four features of Gerstmann? Finger agnosia, right-left confusion, acaliclia, agraphia without alexia. He can't write spontaneously, but if you ask him to copy, he can. That is called agraphia without alexia. Where is the lesion in Gerstmann? If there is any dominant means right-sided guy, left one. Left parietal lobule. Parietal lobe is there, not temporal lobe, frontal, parietal. Parietal lobule, there is a gyrus called angular gyrus. So angular gyrus of the parietal lobe of the dominant hemisphere, which is the left one in a right-handed guy, you get Gerstmann syndrome is what you need to remember. So you can see the MRI, where you are able to see acute infarct in the parietal area involving the gyrus is what you need to remember, which is Gerstmann. Similarly, you can see acute infarct in parietal and also temporal lobe. Left means dominant side. So what is agraphia? Agraphia is loss of ability to express the thoughts in writing. Prema lekha rayadam raatలేదు, agraphia. Loss of ability to perform simple arithmetic problems. Loss of ability to recognize or indicate one's own finger agnosia. Right-left confusion. These are all the problems of the dominant inferior parietal angular gyrus called Gerstmann syndrome is what you should remember. Now comes the anterior cerebral artery. Middle cerebral artery lo emuntadi? Dramatic untadi picture. Cinema dramatic untadi. Etluntadi middle cerebral artery lo? Hemiplegia. हाथा पामा नहीं चल रहे डॉक्टर साहब, वो मिडिल सेरेब्रल है. యాంటీరియర్ సెరెబ్రల్ ఆర్టరీ స్ట్రోక్ లో ఏమైతుంది? Let us see. Anterior artery దేంట్లోంచి వస్తుంది? Internal carotid. Anterior middle రెండు internal carotid. Now, anterior artery, which part of the brain does it cover? It only covers the strip of area which is called paracentral lobule. What is that called? Paracentral lobule. Homunculus అని వినరా physiology-లో? One leg will be dangling down and the whole human being is represented in the motor map in the remaining area. Only leg is represented in this area. So when anterior artery is involved, whenever the paracentral area there is an infarct, only the leg is involved. Which leg, the same side or opposite side? Loud. Opposite side. Contralateral lower limb monoparesis is the feature of anterior artery. అంటే పేషెంట్ कैसे चलना शुरू करता? Like this he will be walking. Whenever you are lower limb, only one lower limb is not able to walk well, everybody think which problem? Orthopedic problem or neurology? Orthopedic problem అనుకుంటారు. వీనికి ఏమన్నా తొంటిలో ఏమైనా ఇరిగిందా, పెద్ద ఆయనకు కాళ్ళు ఇరిగిందా అనుకుని తీసుకుపోయి ఆర్థోపెడిక్స్ దగ్గర పడేస్తారు. ఆయన ఏమన్నా రేపు పొద్దున సర్జరీ గోషపడేద్దాం అంటాడు. ఏమున్నా ఈ లోపల మీలాంటి ఒక మంచి ఎండి డాక్టర్ని పిలుస్తాడు. ఒకసారి చూడండి సార్, నేను కోయిక ముందనే చచ్చిపోయేట్టున్నాడా, కోసినాక చచ్చిపోయేట్టున్నాడా చూసి చెప్పుండి అంటాడు. సో యూ డిడ్ బెబిన్స్కి పాజిటివ్. That means it is not orthopedic problem. What is the problem? Neurological problem. So you told, ayyo, this is neurological problem, Anna. Don't cut, no problem in hip. Show me where is the hip problem. It's not that. Let us open and see, I thought he says. Right? Then you have done a MRI. Then you will see anterior artery stroke. So that's the reason, always remember, anterior artery stroke will not be dramatic like middle cerebral artery stroke because there is no hemiplegia. There is no hemiplegia. Only when hemiplegia is there, half the body is paralyzed, people recognize it as stroke. RMP-CNU will recognize it as a stroke. Otherwise, anything orthopedic problem, sir. Leg not moving, sir, he will say. And take it to orthopedic surgeon. Chalo, tera 2000 le lo jao. मैं देख लेता हूँ पेशेंट को. So contralateral paralysis, sensory loss in the leg. Frontal lobe is important for what? All our personality is frontal lobe. We don't go and slap a guy opposite our table because our brain will inhibit us. We don't go and jump and like an animal kiss the girl of our neighbor or a wife of our neighbor. Why? Because frontal lobe tell she is his wife and she is your wife. Your and his, there is a difference. So please don't jump like orangutan. You can go and jump in your own bedroom, that too if your own wife gives permission. So that is called inhibition. Inhibition is all frontal lobe. You go to washroom in a public place, you don't pass urine because the brain will tell it's public and it will send from higher center inhibitory signals on the bladder. The moment frontal lobe is involved, what will happen? Personality changes. All our learning, cognition, limbic system, what do you have? What are the three components of limbic system? Prefrontal cortex, amygdala, hippocampus, all this constitute the limbic system. So prefrontal cortex is not working if the patient is having anterior cerebral artery stroke. Understand? So that is the reason what happens to the patient of ACS stroke. He is disinhibited. He is shouting. He is jumping. He is undressing in public. He is passing urine inadvertently. That is the personality change. లేదండి మా ఆయన మంచోడే జడ్జిగా చేసిండు, ఈజ్ అ బిగ్ జడ్జ్, పనిష్డ్ సో మెనీ పీపుల్, సడన్లీ హిజ్ పర్సనాలిటీ చేంజ్డ్ అండ్ హిజ్ లోయర్ లిమ్ ఈజ్ అనేబుల్ టు వాక్ అనగానే ఏం బల్బ్ వెలగాలి? Anterior cerebral artery stroke is what you need to remember. Similarly, bladder, continence of the bladder, higher center is in frontal lobe. The moment the paramedian part of the brain is involved, frontal is involved, the micturition center get affected and there is a development of urinary incontinence is what you need to remember. Did you remember? So there are various functional areas in brain which you need to know. Typically, the temporal is the area where you have auditory cortex. Temporal area is the place where you have memory. Occipital, you have vision. Language and comprehension is in temporal area. Language comprehension. Sorry, this is parietal. This is so here in the frontal lobe, you are having self-control, inhibition, emotions, higher intellect, all in the frontal lobe. Understand? So now, this is an example of what? Anterior cerebral artery stroke. Where is the stroke area? This area is there, no doctor? So typically there is a development of altered echogenicity in the brain in anterior cerebral artery stroke, hypodensity. Now if there is, you get abulia. What is meant by abulia? Absence of willpower or inability to act decisively is called abulia. క్లాస్కి పోదామా వద్దా, క్లాస్కి పోదామా వద్దా, పొద్దున 10 నుంచి 6 వరకు ఏడ క్షౌరం అయ్యేదే, ఏం పోతామప్పా కూర్చో. ఇఫ్ దట్ ఈస్ కాల్డ్ వాట్? ఎబోలియా. ఎప్రాక్సియా, యువర్ మోటార్ ఫంక్షన్ ఈజ్ నార్మల్, sensory is normal, deep tendon reflexes are normal. In spite of that, you are not able to move the limb because the planning is not happening in the brain. What is that called? There is difficulty with motor planning to perform the task in spite of a normal motor, normal sensory examination is called apraxia. Apraxia, abulia, they're all the features in a patient who is having anterior cerebral artery stroke is what you need to remember. Now coming to posterior cerebral artery stroke. Most dramatic of all the strokes is posterior cerebral artery. Why? Vertigo. Right? Severe vertigo. Continuous vomitings. Patient is brought. So it is very evidently available, very dramatic is posterior cerebral artery. Most subtle, and you need to be good clinician if it is which stroke? ACA. ACA లో ఓన్లీ మోనోపారసిస్ కదా, ఎవడు గుర్తుపట్టలేడు. ఇక్కడైతే ఏంటి? వామిటింగ్స్ ఉంటాయి, గిరగిరగిరా తిరుగుతూ ఉంటుంది, స్పిన్నింగ్ వరల్డ్. So that is the reason posterior cerebral artery is most dramatic. In that you have limb ataxia, cranial 9 and 10, because we have seen now posterior cerebral artery is supplied. Posterior cerebral artery arises from basilar artery. So the moment posterior cerebral artery is affected, a part of medulla in the brainstem also is affected. So 9th and 10th cranial nerves become paralyzed in case of posterior cerebral artery is what you need to remember. So I leave the literature for you, doctor, about each of these territorial strokes. What are their characteristic features? You should know very well. Whenever posterior cerebral artery is involved, occipital lobe is involved, visual cortex is involved, then the patient develops this kind complete blindness, but macula, central area is spared. That is the feature of PCA stroke. Understand? Why there is a macular sparing? Fundamentally in posterior artery stroke, visual cortex which is there in the occipital lobe is involved. But in the occipital lobe, the visual cortex has two blood supplies. One by the striate arteries arising from MCA and the other is PCA. Rundu supply is the only central vision. Migita part of the vision give only PCA. But central part of the vision, whatever represented in the visual cortex, has dual blood supply. One is the striate vessels of the MCA and also PCA. So PCA occlusion in MCA striate vessels continue to supply. That's the reason macula won't be involved. So what is this called? Macular sparing homonymous hemianopsia is the feature of posterior artery stroke, is what you need to remember. So posterior artery is closely related to your medulla, to the cerebellum, everybody. It supplies. So that is the reason giddiness, vertigo, ataxia, nausea, vomiting, ophthalmoplegia, coma, they're all the features of PCA stroke, is what you need to remember. Clear? SIADH అయిపోయింది, MCA అయిపోయింది, PCA కూడా అయిపోయింది. మళ్ళీ పోయినాక ఏం చేయాలి? రూమ్కి పోయి మళ్ళీ బుక్లో ఉంటాయి, ఇవన్నీ ఉంటాయి. ఎందుకుండే ఉంటాయి, రివ్యూ చేయండి. More detailed, more slow version of this I delivered already in SCORE learning app. ఇప్పుడు 38 paragraph number ఇది. సేమ్ ఈ నోట్స్లో కూడా 38 ఇదే ఉంటుంది. దాని కరస్పాండింగ్ వీడియో ఉంటుంది. Just to do a review of that video. Okay? Now, మీ పేరేంటి డాక్టర్ సార్? ప్రతాప్, ప్రకాష్, వెరీ గుడ్. ప్రకాష్ ఎక్కడ? గవర్నమెంట్ మెడికల్ కాలేజా? సో I just spoke with Ramkishan sir. First of all, who asked you to go and pay 10,000 rupees and go opposite SVS Medical College? Did I not say you can deliver it in medical college, hospital? I said, okay. Confessed, mistake confessed. So then he said, the students of government college by nature are studious, brilliant, and capable of self-preparation. Only you need to give a little extra BCG dose of activating them, that's all. So I told, instead of 30,000 rupees, which we charge only 10,000 rupees, because it costs somewhere around 5 lakhs to organize the 14 Sundays. So that is the reason around at least 40-50 students join paying 10,000. It will become valid and viable in 14 Sundays for me to come and finish the subject for you. So let us take an opinion of your friends, classmates, seniors. మీరు ఏ బ్యాచ్ డాక్టర్ సార్? 18? యాక్చువల్గా 18 వాళ్ళ డేటా లేకుండే మా దగ్గర. So take a consensus and as a group come forward, and we will give you access to the SCORE learning app, the SCORE app.in, all video library, PowerPoints, notes, everything on the web. Then 30 full-scale grant tests and live discussion, daily live online class about an hour, and we also have these 14 Sundays to finish medicine, surgery, gynocs, orthoped. So think about it. If you come forward, I like to take an opportunity to come back next week to continue and finish what we started, right, towards 14 weeks. But I don't know, is the new trend is internship खत्म करने दो जरा, बाद में हैदराबाद जाके आराम से पढ़ेंगे बोल के. But that became a problem because next anyway they're going to introduce this year or next year. What is the say? ఎప్పుడు ఉండదు అంటున్నారు. No idea. 24 next year. ఇంకొంది నడుస్తూనే ఉంది కాబట్టి పర్వాలేదు. బట్ లేకుంటే ఎంబీబీఎస్ పాస్వర్డ్ కూడా కిరికిరి అయిపోతుంది ఒక్కసారి అది వచ్చిందంటే. బట్ ద పాయింట్ ఈస్ ఇట్ ఈస్ నాట్ అబౌట్ next or anything. Definitely there will be a PG entrance. They don't put a running race and whoever runs first will not be given a seat, right? So question is, when we want to, are we determined to get in first attempt or not? Always first attempt, it should be the best attempt. Second, already will be painful. Second attempt, once we fail and to rise is very difficult. MSET అయినా అంతే. 12th అయిపోతుండగానే కొట్టడం ఈజీ. ఒక అటెంప్ట్ అయినాక కొట్టడం అంటే కొంచెం. హౌ మెనీ ఆఫ్ యూ గాట్ ఇన్ ఫస్ట్ అటెంప్ట్ ఇన్ మెడికల్ కాలేజ్? ఒకటి. హౌ మెనీ గాట్ ఇన్ సెకండ్ అటెంప్ట్ ఇన్ టు ఎంబీబీఎస్? అచ్చా, అక్కడ కూడా ఇదే ట్రెండా? पहला इंटरमीडिएट खत्म करो, बाद में बैठ के पढ़ो 1 साल. So but that's the point. So what is a lacunar stroke? If you take the middle cerebral artery, it gives one small branch called lenticulostriate vessel that will go and cause a pointed small infarct, which is called lacunar stroke. This lacunar stroke, how does it present? If that is hitting a area important for our motor activity, only pure motor stroke. If it is hitting an area which is important for sensory activity, only pure sensory stroke. Sometimes it will hit the area of the cerebral cortex where the fibers coming from cerebellum are there. Then it lead to ataxic hemiparesis. Sometimes that pointed stroke will hit an area involved in speech. Then you get dysarthria. So dysarthria, clumsy hand, ataxic hemiparesis, pure motor, pure sensory are the various forms in which a lacunar stroke occurs. Sometimes that small vessel hitting will hit the thalamus. So whenever thalamus is hit, then there will be an intense pain. Such an intense pain, patient will say, oh my God, the flesh from my face, flesh from my body has been taken out of my body, kind of a feeling they get, which is then called thalamic pain syndrome, otherwise called hypersensitive pain response, is the classical feature of lacunar infarct involving thalamus. So you need to know, sometimes pons, this pons is an area where there is a stroke, lacunar stroke. Then pons is an area which is important with connections to cerebellum. That's the reason clumsy hand, dysarthria is a syndrome which will occur whenever there is a lacunar stroke involving the pons. So once more remember, lacunar strokes are divided into pure motor, pure sensory, ataxic hemiparesis, or it can be dysarthria, clumsy syndrome, and you need to know which part of the brain is affected in each of these syndromic presentations, which is a favorite question in NEET PG. So always remember, whenever the patient has a gauge preference, if there is any eye deviation towards the lesion, it is an infarction of the putamen. Whenever there is any seizure, then also eye deviation will be there, but that will be away from the focus of seizure. This is the rule you need to basically remember. Now let us talk about basilar artery occlusion. Basilar artery. So how is basilar artery formed, doctor? The two vertebral arteries combine to form the basilar artery, which divides into the two posterior cerebral arteries. So whenever basilar artery involvement is there, it is ultimately affecting whom? Brainstem. In the brainstem, what do you have? Pons. Correct? So what is brainstem? Midbrain, pons and medulla. So what is the center of afferentiation into the brain? Afferency, all sensory input first goes to thalamus. Similarly, there is a center called Center for Efferentiation. All motor output compulsory passes through that structure. What is that? Pons. So whenever pons is affected, what will happen? Patient cannot raise his upper limb. Patient cannot raise his lower limb. Nothing he can move. He lies down on the bed there. Like this. Understand? Our horizontal gauge. What will happen whenever we do horizontal gauge? You are studying in reading group, suddenly a handsome hunk is going. What will you do? Davidson underlining will be going on, but I will be going, oh, what a guy, what a perfume, oh my God. Huh? So the guy is just passing, but underlying continuing because there is a stress that the handsome hunk is leading you. So horizontal gauge is controlled by pons. There is a peripontine reticular formation which is there in the pons. Then you are a guy who went and proposed. It's so beautiful. Every time you are going to library, my heart is losing the beat. Then what will the girl will do? Kabhi, have you seen your face in mirror? She will ask you. So what is she doing? Vertical gauge. The center for vertical gauge is there in midbrain. Center for horizontal conjugate gauge is there in pons. Please don't forget. So whenever pons is affected, pons has two major responsibilities. What is it? Center for differentiation. Other is, it is the center for horizontal gauge. Horizontal gauge is not happening. Upper limb, lower limbs are not moving. The only thing left over is looking up and down because that is controlled at midbrain, which is still intact in pontine lesion. This is called locked-in syndrome. You are locked in. Your body, soul is locked in inside your own body. Right? So the locked-in syndrome is a feature whenever there is a pontine infarct, whenever there is a basilar artery occlusion, is what you need to basically remember. Patient will be lying down like a frog. One more instance you should remember. Where do you get locked-in syndrome? There is a condition called CPM. What is CPM? Communist Party Marxist. Central pontine myelinolysis. Tell me, what is that? Central pontine myelinolysis. What is the normal sodium levels in the body? Serum sodium 134 to 145. This 134 went and fell down to 120. So how can you replenish this low sodium? Normal saline. What is normal saline? 0.9% saline. Then there should be some abnormal saline, no? Do we have abnormal saline? If you tell sister, no, sister normal saline, then sister will be thinking, ante abnormal saline emuntado maaku cheppale out of syllabus nursing books lo. Right? 3% saline is hypertonic saline. Then you are having half normal saline. Instead of 0.9, you have 0.5%. Why so many types of saline are there? Everything is uppuni legada. NaCl ante. Normal saline, 1 bottle, 1 liter, contain how many milliequivalents of sodium? 154 milliequivalents. 3% saline, what does it contain? 541 milliequivalents. Adamenda? So suppose if my body weight is 70 kgs, how much of it is water? 60%. Correct? Ante enta 42 liters is the water. Agreed? Water is what? Body water. You have total body water. Is how much? 42 liters. Suppose if my sodium is 134 milliequivalents normal, but I have 120 milliequivalents value in the lab, how many milliequivalents am I less? 14 milliequivalents I am less. Agreed? Louder all answers. Any milliequivalents takwa? 120 vadiki 14. Per liter I have 14 milliequivalents less. So total body water is the 42 liters. 42 liters లో లీటర్ కి 14 milliequivalents పెంచాలి అంటే ఎన్ని milliequivalents ఎక్కియాలి నేను? 42 into 14, which is about 570 nearly. I need to administer how much? 570 milliequivalents ఎక్కిస్తే 120 కాస్తే ఏమవుతుంది? 134 అవుతుంది. హైపోనేట్రీమియా కరెక్ట్ చేసేప్పుడు. But if I choose normal saline has how much per liter? 154. How many liters I need to administer to replenish that 570? At least 4 liters. Each bottle is half liter bottle. That means 8 normal saline bottles I need to pump if I choose normal saline to change from 120 to 134. అర్థమైందండి? ఏం అధ్యక్ష మళ్ళీ చెప్పిన లెక్క వచ్చిందా? మళ్ళా ఫ్రమ్ బిగినింగ్ చెప్పుకుందాం. ఫస్ట్ అండర్స్టాండింగ్, యూ డోంట్ నో వేర్ ఐఎమ్ గోయింగ్ టు. Always remember, when you listen a lecture, no, you should know where that man is leading you into. If you don't know where that man is leading to, you are not in the class. That's the reason very good teachers always tell first where they are leading you into and then lead you. Poor teachers చెప్తూనే ఉంటారు సోది. ఇప్పుడు ఫస్ట్ సోది విన్నారు, అర్థమైందా? ఏం విన్నారు? ఓహో, హైపోనేట్రీమియా కరెక్షన్ గురించి చెప్తున్నారు గురువు గారు. అర్థమైంది కదా? చెప్పండి. నార్మల్ సోడియం, loud answers, 134. So in a 120 milliequivalents per liter guy, you need to increase 14 milliequivalent per liter. How many liters is there? In a 70 kg man, 60%. That is 42 liters. So 42 into 14 is how much? Around 600 milliequivalents. If you choose normal saline, every liter has only 154. That means you need to take 4 liters, that means 8 bottles to replenish this 600 milliequivalents. So what will you choose? Abnormal saline, which is hypertonic saline, 3% saline. So 3% saline has 540 milliequivalents. So hardly you require just 1 liter. That means 2 bottles over 1 day you can give. Clear? That is important to understand. So next time when you go as an intern, no? Electrolyte management, fluid management, that make you a great intern. If you manage that correctly in the patient. Altered sensorium is the presentation of hypernatremia. Altered sensorium undi and ante endukundi ante because of hypernatremia. Hypernatremia endukundi and check cheyali. Common cause of hypernatremia in the hospital setting is what? Diuretic. We all give torsemide, ditar, all these furosemide, Lasix, B6, all those things దంచుతారు కదా. దంచితే ఏమైతే మొత్తం యూరిన్ में बाहर गए चले गए तो कहाँ रहता? अंदर नहीं रहता सोडियम. Hyponatremia, altered sensorium, aspiration because you forgot to put trial shoe, and aspiration lead to pneumonia, pneumonia lead to sepsis, sepsis lead to ventilator, ventilator lead to death. పేషెంట్లు ఎట్లా చచ్చిపోతారు? మనం చంపితే చచ్చిపోతారు. అలంతరాలు చచ్చిపోతారు, వదిలేస్తే మంచి బతుకుతారు. రైట్? గవర్నమెంట్ దాఖలా షరీక్ చేస్తే చచ్చిపోతారు. ఎందుకు చచ్చిపోతారు? ఇందువల్లే. అర్థమైందా? సో కాబట్టి రిమెంబర్, టు సేవ్ ఏ పేషెంట్ యూ డోంట్ నీడ్ ఎండి, డిఎం అండ్ ఆల్ దిస్ బడా degrees not needed. Remember, hardly 30 medicines. నెక్స్ట్ అంటే మీ దోస్తులందరినీ పట్టుకోండి గవర్నమెంట్ దవాఖానలో. 2018, 19 వాళ్ళు కూడా ఉన్నారు, 17 వాళ్ళు, 17 వాళ్ళు, 18 వాళ్ళని పట్టుకురండి. 30 మందులు చాలు తెలుసుకోవాల్సింది. పక్కా తెలుసుకుంటే హాస్పిటల్ అంతా మీరు దుమ్ము లేపచ్చు. లివోసాల్బిటమాల్, albuterol, ipredrobium bromide for asthma. What are the inhalers? What are the respules? If you know asthma. Budicort, budinacide, mometasone, few steroids, 2-3. You know how to give steroids. Clear? If you know metoprolol, if you know telmisartan, if you know one alpha blocker like prazosin, if you know amlodipine, if you know nebivolol, if you know carvedilol, if you know bisoprolol, you can manage hypertension. If you know dapagliflozin, if you know vildagliptin, if you know metformin, if you know mixtard, if you know glargine insulin, if you know deglucin, totally 10 medicines, you know diabetic management. If you know cefotaxime, right? If you know levofloxacin, ufloxacin, metronidazole, totally not more than 10 antibiotics we give. Those who have prostate hypertrophy, you will give tamsulosin to let the urine flow. For those who have constipation, you will give a little lactulose to let the constipation happen. To those who have irritable bowel syndrome, continuously passing motions, you will give rifamycin in order to, it's called rifagat. అట్లా మొత్తం 30 మంది తెలిస్తే అసలు మిమ్మల్ని ఆపేటోడు లేడు. But what is wrong imagination in our life? We should become MD, Somebody should hold our hand, do Aksharabhyasa, make us to learn. Right? When you go into practice, you will find surrounding RMP Sino. Sir, methylpred goteshna. 16 mg methylpred goteshna varan రోజులు జర్ర ఫీవర్ ముందు తగ్గింది, తర్వాత పెరిగింది, మెనింజైటిస్ కూడా వచ్చేసింది. చూసుకోండి సార్ జర మీరు. Outside, left and right, they are writing medicine. Quacks are 62% patients go to not a qualified doctor, to a quack. Whereas MBBS passed out don't have confidence even to open a clinic. Treat his own mummy's upper respiratory infection also. Erythromycin iste emaitundi? ఏమన్నా సైడ్ ఎఫెక్ట్స్లో ఏ సైడ్ ఎఫెక్ట్ వస్తుంది అని పుస్తకం చదువుతూ ఉంటారు. సో లీవ్ ఆల్ దట్ నాలెడ్జ్ ఇన్ ద బ్యాక్ యార్డ్. Go with love, go with compassion, listen the story of the patient. That itself is 10 times reading Davidson and Hatson. Will you promise me to that? Everything కొంచెం చదవాలి, ఒక 4-5 పాయింట్లు. మల్టిపుల్ స్క్లెరోసిస్ అంటే ఓ ఇది, ఎస్ఎల్ఏ అంటే ఇది. పోడే లైన్గా 100 ఓపీ ఉంటుందా, 500 ఓపీ ఉంటుంది, 500 ఓపీ is there. అందులో 300 people only come for getting a overall tablets for them. It's okay. But 200 patients, still you have diabetic, hypertensives, those who require insulin, right? Who have atrial fibrillation, who have placidomegaly, who are having ovarian cancer, carcinoma cervix. They are the ones you need to run, chase for the patients. Within yourself, you need to raise a case discussion, right? And ask me, I am available for you. You pick up a case and ask me, let us discuss this case, sir. I am ready, right? So that is how we should get the knowledge, doctor, not by roaming around the wards meaninglessly, looking forward for a ajnabi, anonymous messiah come and change our life. Nobody will change our life. We need to change, our classmates will change our life, more or less, right? So, doctor, that is the story which you need to know. Now, let us quickly go to 2 important infunctions. Aika, Paika. What is that? Aika and Paika. What is Aika? Anterior inferior cerebellar artery infarction is called Aika. Posterior inferior cerebellar artery infarction is called Paika. So, Aika typically supplies the lateral aspect of the pons, is what you need to remember. Whereas lateral aspect of the medulla is supplied by Paika. So fundamentally, if you look at all the descending tracts, no doctor, which are passing from the brain towards the spinal cord, they need to pass through midbrain and pons and medulla. Some of them pass through the lateral aspect, some of them pass through the medial aspect. You need to know which one pass lateral, which one medial. Accordingly, lateral part of medulla is involved. If you know what structures are in lateral part of medulla, if you do a cross section, they all get affected in lateral medullary syndrome. That is what you need to basically understand. So whenever there is any Paika stroke, the lateral medulla is affected, and that lead to dysphagia, hoarseness, decreased gag reflex, ipsilateral Horner syndrome. They are all the features of what? Lateral aspect of medulla. Wellenberg syndrome is the name given to it. Then, whenever Aika is involved, see, remember one thing. You have cerebellum and you have the brainstem with midbrain, pons and medulla. This cerebellum is connected to the brainstem with three peduncles called cerebellar peduncles. ఏముంటాయి cerebellar 3 ఉంటాయి చెప్పండి superior, middle, inferior cerebellar peduncle. Inferior cerebellar peduncle connects medulla and cerebellum, middle pons and cerebellum, superior midbrain and cerebellum. Mood cerebellar peduncles. What are they connecting? Cerebellum and brainstem are connected by these cerebellar peduncles. Superior, middle, and inferior cerebellar peduncle. So all the spinal cord brings information to whom? To the medulla. From medulla, it sends information copy to who? To cerebellum. In turn, I'll just take this call. CT and all. In a reproductive young woman, don't forget to ask LMP, because if she's carrying by chance, she has amenorrhea, 5 weeks amenorrhea, by chance if you do CT, it becomes difficult. So yesterday I have seen one patient, she is 98 kgs weight, 5 feet 2 inches, 20 kgs overweight. Her TSH values are running around 48. Normal TSH is up to 6, right? Then she is on levetiracetam and carbamazepine, 2 anti-epileptics. Continuously she is having, in spite of that, regularly seizures. She delivered a baby 9 months ago. Currently she is having an abdominal mass lesion. So I am getting evaluated for CT. So always remember, 1 hour you should, if you study, 5 to 6 hours you should plan to be with patients. Right? Most patients, they will take out a big list of their investigations. You go through what those doctors have written and all that. Some part of story you will understand. So go with an attitude to help the patient a right direction to resolve their presenting problem. So in this case, this girl's presenting problem is, मुझे भूख नहीं लग रहा है, मुझे भूख नहीं लग रहा है, और उल्टियां आए तरह महसूस हो रहे, nausea. So I got a LFT done, right? And I asked for a LFT to check whether there is any liver enzyme affected. Why liver enzyme can affect in this patient? Because she is on anti-epileptics. So morning we studied, no, levetiracetam, carbamazepine, all those drugs she is on. And also, in spite of, she is taking 150 micrograms of thyroxine. In spite of that, her hypothyroidism is very high with TSH of 45. So what could be the possibility? Is there any drug interaction between the anti-epileptics and the thyroxine that she is taking? Understand? So every day you should analyze a case, talk to patient, understand what's the problem, what he is struggling for. There you will discover the correct answer. That is the whole purpose of studying general medicine, surgery, gynecology, obstetrics and all that. The moment you become a brother, daughter, son in the patient's life, grandson in the patient's life, automatically studying these things in the book become interesting. అట్లా కాకుండా పేషెంట్లకి స్టోరీకి దూరంగా ఉండి, right? We only read for exams to get distinction, to pass exam. It doesn't take anywhere. I'm telling you. మీరు రోజు సప్లిమెంట్ చేయండి, ఒక 5 పేషెంట్లని ఉత్తగా వినండి. అసలు ఎందుకు వచ్చారు దవాఖానకి, ఎందుకు వచ్చినా, ఎందుకు షరీఫ్ చేసాడు మిమ్మల్ని, ఏదో ఒక ప్రాబ్లం చెప్తున్నా వాడు. The moment you are wearing stethoscope and apron, you are a god for the patient. So क्या बोल रहे सुनो, उसका जिंदगी कैसे सफर हुआ इतने साल, क्या क्या दिक्कतें हुए, क्या क्या ऑपरेशंस हुए उसको, इसके पास क्या क्या रिपोर्ट्स हैं, वो क्या क्या दवा ले रहे, वो पूरा दवा को वहां रखने के लिए बोलो और देख लो क्या क्या है वो दवाओं में. That will make you a great doctor. Unfortunately, 50 years ago, there is no, I mean, at least 80 years ago, there is no Davidson-like book. Patient is the God. Patient tells the story. Ronald Ross discovered mosquitoes plasmodium by dissecting it on Hussain Sagar. There is a Ross Institute of Malaria. Ronald Ross, Hyderabad is credited for discovery of mosquito. Right? So how did it happen? He was closely following the fever pattern of the patient. And then he felt mosquito may be responsible, and slowly he discovered. Like that, even today, even though CT, their MRI, they all are there. What is more powerful than all those investigations? Two things. History is the thumb. Second powerful thing, your beautiful mind, studied with little knowledge. Right? Suppose somebody has fever, you did complete that picture. You found WBC count high, but lymphocyte count is high. Then it is viral. Let's continue. Pica, Ica. Two kinds of strokes we are talking about. So, Pica and Ica. Pica supplies lateral medulla, Ica supply lateral pons. So, pons is connected to the cerebellum through middle cerebellar peduncle. Below pons, medulla is connected by inferior cerebellar peduncle. Both of them are supplied by Ica. Similarly, Ica is causing lateral part of the pons affected. In that, which cranial nerve is there in the pons? Third, fourth midbrain, 5, 6, 7 mid pons. So facial nerve paralysis will be found. So facial paralysis, if it is there, then that is the unique thing to say this is a Ica stroke. Whereas in medulla, what is the cranial nerve nuclei you are having? 9th, 10th, 11th and all. So vagus, glossopharyngeal, they are all in medulla. That's the reason dysarthria, hoarseness of voice, decreased gag reflex, ipsilateral corner, they are all the features of lateral medullary syndrome caused by pica. Unique features. That is what you need to basically understand. So, Ica is lateral pontine, pica is lateral medullary syndrome. You should know what is the clinical presentation of each of them. Clear? Now you know MCA, ACA, PCA, lenticular stroke, lacunar stroke, basilar artery stroke, Inka. Ica stroke, pica stroke. Yes. Only left is one, going and seeing patients, running and chasing the MRIs, identifying my first case of pica, my first case of pica. Okay? So, how many of you are not there in our WhatsApp study group? Anybody? Unnara under WhatsApp study group. Unnara? Are you there? You're not there? Koncham, please share that. Meeru? Lera? Lera? Unnara? So, Suresh, just share them. Balaki WhatsApp study group join gandi. Any clinical case make doubt undanukondi, you want to discuss. Sir, patient ki the problem undi, ivi mandulu eskuntunnadu. Idi emai untadi, let us have discussion. You put it. 24/7 I will be there to discuss the cases. All right? So, transient ischemic attack, TIA. उसका मतलब क्या है? बड़े तूफान आने के पहले कुछ रेन ड्रॉप्स गिरेगा. Those sprinkle of drizzle is an indication that there is a tempest going to come ahead, right? So that is TIA. How do you define TIA? Sir, morning breakfast chesesappudu sir, moothi koncham timmiripoyindi. There is a numbness in my mouth, sir, and hand not working, sir. But within 1 hour, sir, I became all right. Tell me now, what shall we do? Now everything normal, sir. That is TIA. A neurological deficit is there, but it will be lasting less than 24 hours, right? But most will last less than 1 hour to be called as TIA. If you do MRI on him, it is waste because 7,000 rupees wasted. There will be no findings on MRI. That is TIA definition. So already we discussed pica. What are the clinical features of pica? Pica, lateral medulla. In the lateral medulla, spinothalamic tract will be passing. So contralateral loss of pain in temperature. Through that, nucleus ambiguous is present in lateral part of medulla. What is nucleus ambiguous? It is a common nucleus for vagus and glossopharyngeal. Common motor nucleus for vagus and glossopharyngeal nerve. So that is the reason there is a dysphagia. Vagus is involved. Dysphagia, dysphonia, diminished gag reflex, a part of lateral medullary syndrome. Similarly, sympathetic fibers which are started in hypothalamus, they pass through the brainstem laterally and reach the cervical sympathetic plexus. So that is involved. That's the reason there is a Horner syndrome. Inferior cerebellar peduncle arise from the lateral part of the medulla. Hence, ataxia. So these are the various features of pica. That is the lateral medullary syndrome is what you need to remember. So whenever there is any hemiplegia, etc., first investigation to do is what? Non-contrast CT. Why? If you do non-contrast CT, at least you will know hemorrhage is there or not. If it is a hemorrhagic stroke, you can't give thrombolytic. Only if it is a ischemic stroke, you can give thrombolytic. So you should know before you give thrombolytic, what are all the contraindications? One of the favorite question of the examiner. What are the contraindications of giving tissue plasminogen activator, TPA therapy? I'll leave the literature for you. So you have a patient who has hemiplegia. He is in acute ischemic state in the brain. What do you want to do? If it is less than 3 to 4.5 hours, then you can give thrombolytic. Second, lot of times when a cerebrovascular accident stroke patient comes to you, the BP is very high. But don't bring it back to 120. There is something called permissive blood pressure. Bring it to less than 185 systolic, less than 110 diastolic. Antakante avsaram le drastic ga taggedam. 210 undi. Bring it to less than 185. Till there. Treat the fever. Typically stroke patients present with fever, hyperthermia, hyperglycemia. If these two things develop in a patient of stroke, poor prognosis. Treat it. Give aspirin. If more than 3 hours happened already, golden period over. Patient with stroke came. Give aspirin. And always whenever there is a stroke, there is an edema. Edema will cause compromise of other important structures. So reduce brain swelling. Reduce intracranial pressure. Prevent herniation of the brain. Give mannitol. Give hyperventilation with ambu so that it will purge out carbon dioxide. And that will also decrease the hypocarbia. Induce it so that it will bring the ICP down. Put a rail shoe, prevent aspiration pneumonia, prevent UTI, prevent DVT. They are all the part of the management. It is what you need to remember. Already we discussed Wellenberg syndrome. Similarly, medial medullary syndrome also. You should know what structures are there. And because those structures affected, what are the symptoms are there? Just you need to know. So I leave the literature for you. This is an example of what Dr. Lacunar stroke, just a dot of lesion is lacunar stroke. So what is the cause of lacunar stroke? Is my question to all of you. We finish in another half an hour, right? You bring 50 students, I'll teach up to 8 o'clock. But still, I mean, the point is, evening once more, late evening, I have about a half a dozen patients waiting in the OP. So that's the reason if I go a little early, Mehboob is nothing. It's just like coming to Shamshabad airport. Inkoka araganta tokkite idaku vachestam. So it's not too far. How many of you are from Hyderabad? Anybody? 1, 2. So what is the etiology of lacunar stroke? Whenever the person is not controlling his atherosclerosis, hypertension, those atherosclerotic arterial sclerosis of the vessels, small vessels, which are supplying, they are called lenticulostriate vessels, supplying the basal ganglia, subcortical white matter, pons, they all get infarcted in a point way. That's called lacunar. Hypertension, diabetes, advanced age, high LDL, smoking, they're all the risk factors for lacunar stroke. How does it present? 4 syndromes. Pure motor, most common. Pure sensory, ataxic hemiparesis, dysarthria, clumsy hand syndrome is what you need to remember. When do you want to give thrombolytic therapy? Whenever there is an ischemic stroke and you are able to see a measurable neurodeficit, that means hemiplegia or facial weakness, sensory loss, ఈ డెఫిసిట్స్ ఉండి hemorrhagic stroke కాకుండా ischemic stroke అయితే you can treat with thrombolytics. And the onset of the symptom should be less than 3 to 4.5 hours. Then what are the strict exclusion criteria? Hemorrhagic stroke, don't give thrombolytic. He will die because of your drug. Multilobar infarct, don't give. If there is any head trauma or a stroke in the past 3 months, don't give. Any brain neoplasm is there, don't give. If the platelet count is low, if the BP is more than 185 by 110, or if there is any severe hypoglycemia with the glucose less than 50, don't give. So please remember all these exclusion criteria. Similarly, some of them are absolute, some are the relative contraindications. You should know which are absolute and relative. Paragraph number 56. Just revise that. So ultimately, notes is everything, doctor. I have given Unda Babu notes in the Nigra, Suresham. ఒకసారి నోట్స్ అందరికి 3 కాపీలు అందరికి ఒకసారి ఇచ్చి మళ్ళీ తీసుకో, రైట్? సో దట్ లెట్ దెమ్ హ్యావ్ ఏ ఫస్ట్ హ్యాండ్ ఫీల్ ఆఫ్ వాట్ ఉందా. కొంచెం కట్ తిప్పి ఒకసారి నోట్స్ ఇవ్వండి. నౌ basal ganglia may, if there is any hemorrhage, then you know basal ganglia, no? Just morning we discussed Parkinsonism and all. You get contralateral hemiparesis, hemisensory loss, homonymous heminopsia, gauge palsy. These 3 problems in basal ganglia. Aithe gauge palsy undi chusara. If it is a cerebral stroke, gauge will be towards the affected side. But if it is a stroke involving basal ganglia, gauge will be away from the side where the lesion is. Gurtuntuda? Basal ganglia, gauge palsy is away from lesion. Cerebral stroke, towards. That's what you need to remember. If the cerebellar stroke You know, this area is all what? Cerebellum. This is all cerebellum. If there is any bleeding to cerebellum, there will be no hemiparesis. And tone strength of the muscle is not same. Spasticity, flaccidity, rigidity. What are we talking about? Tone. Ramaya cheyyatavaya. Ramaya cheyi kadilinchvaya. Ramaya nen cheyi addam beditavaya. What are you testing there? Strength. Strength adi. Against gravity, against resistance. Sidewise movement is there or not. That is what strength. But spasticity, rigidity, flaccidity, we are talking about tone. Don't confuse. Cerebellum is associated with tone. Cerebral motor cortex is associated with strength. And also it leads to hypertonicity, upper motor neuron. So a cerebellar hemorrhage like this, usually no hemiparesis. But there is a facial weakness in cerebellar hemorrhage. Ataxia, nystagmus, occipital headache, neck stiffness, they are all the features of the cerebellar hemorrhage. Putamen is the most common location for the hemorrhage in hypertensive. But cerebellum is a classical location of a hypertensive hemorrhage is what you need to remember. Okay? So this is an example of what? Thalamic hemorrhage. This is cerebellar hemorrhage. And this is a ganglionic bleed, basal ganglia. The rule is, whenever thalamic bleed is there, the bleed is horizontally oblong, like the letter T. Whenever papilloganglionic bleed is there, it will be vertically oblong. There are all few funda radiological. One day some of you become top radiologists. So wherever I go, in any hospital, one or the other of my student will be there. Your Ramkishan sir is there, no? Medical superintendent. 3 years senior to me in MBBS in Gandhi. I used to be just 45 kilos when I joined Gandhi. I was so scared with the seniors ragging, I thought leaving the medical college and running away. There used to be one guy who is a commissioner's son. Wow, he's a proper gun. Ram Kishan, once a group of seniors were pushing hard. Then he came and held them and said, this puny boy, 45 kgs, comes from Telugu medium, from a small village, and you bloody fellows are threatening his existence. I still remember that Ram Kishan coming and rescuing me. When I started coaching, first batch, there are almost 180 students from Usmania, Gandhi, Deccan. I myself was preparing for entrance exam. Ram Kishan was also sitting in the front bench. Ram Kishan, after 5 years, he made it to MS Orthopedics, post MBBS, serving government, right? So that way, he still owes me to offer a lecture hall for you guys, right? He was such a super senior, but at the same time, he was among the batch of the first group of students to whom I gave coaching. And in that batch, 100 May, 88 students got in top rank. I myself got first rank and joined NIMS. So always remember, best way to become a topper. Teach, have 3-4 sishyas along with you, or 2-3 gurus along with you, but a batch. of mavericks and hustle with a single dream to get into MD. Once you get into MD, there is no bigger competition in life. Everything else is selling yourself. You have to convince patient that you are the best guy. You touch and thrombolysis will happen on the head. That kind of patients develop that kind of feeling towards you. ఎంత బాగా చెప్పారు డాక్టర్ గారు. నా గుండెలో క్లాట్ కరిగిపోయింది. గుండెలో క్లాట్ కర్నరీ ఆర్టరీను కొవ్వు తిన్నది అట్లా కరిగిపోతున్నారు ఆయన. కొంచెం నువ్వు రైస్ తింటాం బంద్ చేయాలి బతులాడాల్సి వస్తుంది పేషెంట్లని. సో నౌ thalamic bleed, let us talk about it. Whenever thalamic hemorrhage is there is a contralateral hemiparesis, contralateral hemisensory loss. Thalamic bleed lead to non-reactive meiotic pupils and the eyes deviate towards the side of hemiparesis. Stroke etuntedo atuvepki the eyes will deviate. Right thalamic bleed will make eye deviate to right side. Left will make left towards the left side. Clear? That is the reason every stroke patient you need to look at the pupil. Why? Pontine bleeding lead to pinpoint pupils. Thalamic bleed lead to meiotic pupils. Midbrain infarct and bleed lead to dilated pupils. Atla. Pupil has a lot of significance for you to localize the site of bleed is what you need to remember. ఈ ఎంఆర్ఐలు వచ్చినాక ఇవన్నీ కొట్టుకుపోయినాయి. అన్ని పులిహోర కబుర్లు ఇవన్నీ కూడా. ఒకప్పుడు పెద్ద కొట్టేది. एक जमाने में जब एमआरआई नहीं थे, क्लिनिकल एग्जामिनेशन करके बेटिंग मारते थे कि ब्लीडिंग कहाँ हुआ होगा. Patient is pathetic state, doctor is in idiotic state, idiopathic, right? So once MRI came, if you know that MRI may something is expected, enough. To whom MRI should be done, enough. Okay. Now, whenever the bleed happens into the cerebral lobe, what will happen? Ichara andarki మూడు కాపీలు ఉన్నాయా మీరు చూడండి. 3 copies. 3 copies, 1200 pages are there. All 19 subjects are being covered. ఒక్కొక్కటి పేరాగ్రాఫ్ వైజ్ ఉంటుంది డాక్టర్. ఒక పేపర్లో 8 to 9 paragraphs ఉంటాయి. దట్ పర్టికులర్ ఈచ్ పేరాగ్రాఫ్లో 4-5 వెరీ హై yield పాయింట్స్ ఉంటాయి. రైట్? ఇది మాస్టర్ చేస్తే ఇనఫ్. అయితే each paragraph, whatever the paragraph you are seeing here is there in the notes. The paragraph is discussed in 4 to 5 minute video. Like that 5,000 videos are there of 600 hours duration. Additionally, all these PowerPoints along with the images, everything is made available in the both app and also in the web. The whole thing, we will try to package it to give you at a most affordable price. More important is apps don't make you topper. Books don't make you topper. The moment you get that motivation to consume them, actively recall and repeat them spacedly, discuss among the friends, will only give you the seat. Okay? And I am there as your classmate, roommate, benchmate, tablemate, playmate to help you to read every day, achieve, get inspired, be motivated, positively directed to become the topper. Until you become topper, I will hold your hand. Whether you subscribe to our course or not doesn't matter for me. We met itself is enough, right? So be part of our WhatsApp study group and also subscribe so that it will help you, your preparation. So cerebral lobe hemorrhage. Whenever frontal lobe is involved, there is a contralateral hemiparesis. Whenever parietal lobe is involved, contralateral hemisensory loss. Whenever occipital lobe is involved, homonymous heminopsia, and the eyes will deviate away from hemiparesis. Ante kada, eyes deviate towards the side of lesion, and the hemiparesis is contralateral to the side of the cerebral lesion. That's the reason cerebral lobe hemorrhage lead to the eyes deviated away from the side of lesion and towards the side of lesion and away from hemiparesis. Clear? And cerebral hemorrhage lead to hemorrhage, not infarct. Hemorrhage, not in ischemia. High incidence of seizures. So, doctor, this is parietal lobe. This is occipital lobe hemorrhage. This is pontine hemorrhage. This is the pons, where you get pinpoint pupil. Pons also has reticular formation, and that will lead to development of a deep coma. Pons is the area of efferentiation. That is the reason there is a quadriplegia. So is what you need to remember. So this is a patient who is in the locked up syndrome. This is called as. He can't move his legs. He can't move his hands. He can only do vertical gaze, not even horizontal gaze, because his pons is having bleed. ఇంతకుముందు నేను మర్చిపోయిన మధ్యలో వదిలేసిన హైపోనైట్రీమియా గురించి చెప్పుకుంటున్నాం కదా. ఇప్పుడు హైపోనైట్రీమియా స్టోరీ ఎందుకు వచ్చిందంటే పాన్స్ అనగానే హైపోనైట్రీమియాని మీరు per day not more than 8 milliequivalents per liter you can't raise the sodium levels. If you rise more than that dramatically, then in the pons all myelin get broken down. Central pontine myelin lysis occur, and the patient will be lying down like a frog in the bed. CPM is a complication of a rapid correction of hyponatremia more than 8 milliequivalents per liter in a day, and that presents in the form of a locked up syndrome is what you need to remember. So, doctors, next comes a very important topic called subarachnoid hemorrhage. Subarachnoid hemorrhage. What are the three meninges that we have? Dura, arachnoid, paya. Below that is brain. Paya tightly abuts your brain. Between arachnoid and paya, the bleed is called subarachnoid. Between arachnoid, so you have dura, arachnoid, paya. Outside the dura, what do you have? Calvarium. Between calvarium and dura, you call epidural hemorrhage. Below the dura, above the arachnoid, you call subdural hemorrhage. Subdural hemorrhage is venous bleeding. Epidural hemorrhage is artery bleeding from middle meningeal artery, which is abutting the calvarium. And subarachnoid is involving between arachnoid and paya, and that is the reason into the sulci between the gyri it get accumulated, and that is what you typically see the bleed in the area called sylvian fissure. These are all the sulci. Sulci gyri untayi kada, sulci gyri itla undi, దీనికి అతుక్కుని ఏముంది పయా ఉంది, దాని పైన arachnoid మధ్యలో బ్లీడ్ అయింది అనుకోండి, అది ఎక్కడ కలెక్ట్ అవుతుంది? సల్కాయిలో. సో అందుకోసం నార్మలీ యూ డోంట్ ఫైండ్ బ్లీడ్ ఇన్ ది sulci, but if you find the bleed in the sulcus, especially this is called sylvian fissure, that is subarachnoid hemorrhage. What is the most common cause of subarachnoid hemorrhage? Anterocommunicating artery has an aneurysm which undergo a rupture, and that lead to bleeding into subarachnoid space is what you need to remember. What are the complications of subarachnoid hemorrhage? Within first 24 hours, there can be rebleeding. There is a vasospasm after 3 days. There is a development of hydrocephalus, seizures, syndrome of inappropriate ADH secretion lead to hyponatremia. ఇవి సబరకినాయిడ్ హెమరేజ్ కాంప్లికేషన్స్. ఇప్పుడు బ్లీడ్ ఎక్కడైంది? అవుట్ సైడ్ ద పయా మ్యాటర్. సో ఇప్పుడు ఇది బ్రెయిన్ అండి. దీనిపైన పయామెట్రీ ఇట్లా ఉంది, అతుక్కుని ఉంది. దానిపైన యు ఆర్ హ్యావింగ్ subarachnoid, arachnoid. So bleed is there in the subarachnoid space, not inside the brain. If it is inside the brain, then you need to develop what? Hemiplegia and focal neurological deficits. That's the reason you don't have hemiplegia. If the bleed is subarachnoid, outside brain. But sometime what will happen? The blood vessels entering into the brain, when they are passing through the subarachnoid space, all that bleed around them will lead to intense vasospasm. That will lead to hypoxia, leading to focal neurological deficits. That's the reason, what is the goal of subarachnoid hemorrhage? Prevent vasospasm is the most important goal. Prevent vasospasm. How can you prevent vasospasm? Give a vasodilator. Give a vasodilator like nimodipine. Hydrate the patient. Hyperventilate the patient with ambu. Because hyperventilation leads to hypocarbia. Hypocarbia vasodilates. So give nimodipine, calcium channel blocker. Hydrate the patient, run fluids, hydrate the patient, and give hyperventilation. By all those measures, you can avoid the vasospasm and you can avoid the focal neurological deficits, is what you need to remember. Clear? Then a subarachnoid hemorrhage patient is altered sensorium. What is the cause? Hyponatremia. Why hyponatremia? Because of SIADH. ఒక రెండు పంక్తులు SIADH గురించి చెప్పుకుందాం. వినరా? సియాద్ అంటే SIADH అని వినరా? Normally, when do you get ADH production? Whenever you are dehydrated, when your plasma osmolarity is high, that stimulates the ADH. Clear? That stimulates the ADH. But even if your plasma osmolarity is not high, you are not dehydrated, but why ADH is produced? That is called SIADH. With a normal osmolarity only, if the ADH is produced, it's called SIADH. Whenever SIADH is there, antidiuretic hormone, it will lead to prevention of diuresis. Antidiuretic hormone is what? Preventing diuresis. If it is inappropriately produced, what will happen? Inappropriately diuresis is prevented and all water is retained. All this retained water will cause plasma osmolarity to go low. Clear? Then what will happen? All this retained water expands the plasma volume. That increased plasma volume will stretch the atria. Atria then produce atrial natriuretic peptide that will go and cause natriuresis. That's the reason urinary sodium levels become. What happens natriuresis ante? Increased. మీరందరూ ఆన్సర్ ఫట్టు ఫట్టును కొట్టాలి రివర్స్లా. మీరు మంచిగా వింటారు హ్యాపీగా. నాకు అర్థమవుతుంది, మీకు అర్థమవుతుందా కావట్లేదా? అవుతుందా? అవుతుందా? మరి ఆన్సర్ చెప్పండి. I leave a pause while I'm talking. You fill the pause. Not with your whisper, but with an answer. Okay? మళ్ళీ రండి. మళ్ళా కిక్ కరెక్ట్గా ఎక్కాలి. టెకీలా షాట్ లెక్క. అర్థమైందా? ఆల్ ది జనరల్ యు ఆర్ డాక్టర్ మురళీ భరద్వాజ్ స్టూడెంట్స్ అంటే జనరల్ మెడిసిన్ టాప్ లేచిపోవాలి, తగ్గేదేలా. సో బీ వెరీ ష్యూర్, బీ 100% ష్యూర్, దుమ్ము లేపడే. నౌ SIADH, antidiuretic hormone, is inappropriately produced. Inappropriately diuresis prevented. That lead to water. గట్టిగా అసలే నాకు ప్రెస్బయాక్సిస్ నిజంగా. fill my ears. Water retention. Retained water lead to plasma osmolarity to become decreased, and that cause the plasma volume to become increased. That will cause the atria to stretch. That will make secretion of atrial natriuretic peptide. That lead to natriuresis. That means urinary sodium will become increased or decreased? Increase. That is the reason to define SIADH. What is the laboratory criteria? Plasma osmolarity should be increased or decreased? ఇదా గట్టిగా చెప్పు, నాకు వినబడుతుంది. What happens to plasma osmolarity? వాటర్ రిటైన్ అయితే ఏమవుతుందమ్మా? ప్లాస్మాలో వాటర్ ఎక్కువైతే డిక్రీజ్ అవుతుంది. ఇంక్రీజ్ అంటే యాంటీడైరెటిక్ హార్మోన్ వాటర్ రిటైన్ చేస్తుందా? డైరెసిస్ ప్రివెంట్ చేసి దాంతో ప్లాస్మా ఆస్మోలారిటీ ఏమవుతుంది? ఇంక్రీజ్డా? డిక్రీజ్. గుడ్. వాటర్ అంతా బ్లడ్లో ఉంటే వాటర్ యూరిన్లో లేదు, అందుకోసం యూరిన్ ఆస్మోలారిటీ ఇంక్రీజ్. యూరినరీ సోడియం ఇంక్రీజ్, రైట్? అండ్ సోడియం అంతా యూరిన్లో పోతే ప్లాస్మాలో సోడియం డిక్రీజ్. సో ప్లాస్మా సోడియం ఈజ్ లో. 4 laboratory criteria to call SIADH. మళ్ళీ చెప్పుకుందామా? కరెక్ట్ ఆన్సర్ చెప్పాలి. యూరినరీ సోడియం గట్టిగా, ప్లాస్మా సోడియం, యూరినరీ ఆస్మోలారిటీ, ప్లాస్మా ఆస్మోలారిటీ. ఓకే, ద క్రైటీరియా. ఎవరిలో? In a patient who is not dehydrated, whose liver function is normal, whose kidney function normal, whose thyroid function normal, who doesn't have ascites. Euvolemic individual la hyponatremia unte cause is SIADH. It's a diagnosis of exclusion. All right? So doctor, whenever subarachnoid hemorrhage is there, there is SIADH. ఫల్ల గాలేసి నిద్ర వస్తుంది. ఏమంటావు ప్రకాష్? ఏ బాధలన్నీ మధ్యాహ్నం పూట హ్యాపీగా So that is the subarachnoid hemorrhage. How do you diagnose? నాన్ కాంట్రాస్ట్ హెడ్ సిటీ. ఎందుకు నాన్ కాంట్రాస్ట్? హెడ్ల సిటీ స్కాన్ చేస్తే ఏం కనబడుతుంది? సిల్వియన్ ఫిషర్స్లా బ్లీడింగ్ ఉంటుంది. కాంట్రాస్ట్ చేస్తే మళ్ళీ కన్ఫ్యూజన్, ఇది బ్లీడా కాంట్రాస్ట్ తెలియదు, అందుకోసమే నాన్ కాంట్రాస్ట్. లంబార్ పంక్చర్, if you do, what will happen? All that bleeding is subarachnoid, it will go into the spinal cord and comes out to the CSF tap. It will be bloody CSF tap. Xanthochromia, that is typically CSF may, there is a yellowish coloration because the bilirubin by the breakdown of the RBCs. Cerebral angiography is used to diagnose. This is the normal, this is the xanthochromic CSF. How do you treat? The source of the subarachnoid hemorrhage, where is that located, doctor? Bury aneurysm in the anterior communicating artery. So put a clip and obliterate the aneurysm so that it doesn't bleed. So that's the reason. Coiling, stunting, endovascular therapy you will do. Give nimodipine, hyperdynamic therapy to prevent vasospasm. What is the kind of presentation of a patient with subarachnoid hemorrhage? Such a severe headache, doctor, oh Italia, I can't be able to tolerate it. Please help, doctor. He'll be crying. Whenever your patient say, never in life, even on first night, second night, third night, also he didn't have that kind of pain. Or after the marrying a girl also he didn't have that pain, means subarachnoid hemorrhage. Like such an excruciating, like thappad maar ke aa gaya, thunder clap, like a lightning strike. I have the pain, is subarachnoid hemorrhage. Because of all that bleed into the subarachnoid space, there is a meningeal irritation. Because of that, there is a neck stiffness, photophobia, nausea, vomiting, Kernicks, Brudzinski, all these irritability signs. When you stretch, the meninges will be there with subarachnoid hemorrhage. But more than 1/3 of the patients, they will have a sentinel bleed, warning leak. Few days before also this severe pain came. Now severe pain came, finished. After 2-3 hours, patient can't talk anything. He is already in subarachnoid bleed. So sometimes it can lead to frank coma and even death. We do 4-vessel angiography to identify where is the aneurysm, and accordingly we need to clip that aneurysm, is considered to be the treatment. So what is the management, doctor? Neurosurgery. Anytime, prevent rebleeding, give calcium channel blockers, hyperventilation, do serial lumbar punctures. They're all considered to be the management. What is the main complication? Vasospasm should not occur. So hydrate the patient well is the most important. Got it? So ఇంతటితో మన సమావేశాన్ని పూర్తి చేసే అధ్యక్ష. మరలా ఆదివారము రావాలంటే you need to form a little group among your friends in government medical college. Come forward as a group. If you give a confirmation that at least 40 to 50 are ready to attend and join the course, I am all with you, right? So, but otherwise, ఈ ఆర్థోపెడిక్స్, పీడియాట్రిక్స్ అన్ని చిన్న చిన్న చిల్లర సబ్జెక్టులు అన్నీ. ఆస్టియోజెనిక్ సార్కోమాలో సన్బర్స్ట్ క్యాల్సిఫికేషను, ఇవింగ్స్ సార్కోమాలో ఆనియన్ పీలింగు, గ్యారీస్ ఆస్టియోమైలటిస్లో ఎమెలైడాసిస్, అంత పులిహోర. అది ఎప్పుడైనా చదువుకోవచ్చు, ఒకటి చెప్తే చదవాల్సిందే. కానీ గైనాప్స్లో కొన్ని ఇష్యూస్ ఉంటాయి, లైక్ అండర్స్టాండింగ్ ద రిప్రొడక్టివ్ సైకిల్, ఇన్ఫర్టిలిటీ. మళ్ళీ అన్ని మెడిసినే. అట్లనే రోబర్ట్స్ మాన్యువర్, మార్షలీ మర్చ్ క్రాన్స్ ఆపరేషన్, డిఫరెంట్ కైండ్స్ ఆఫ్ ప్రొలాప్సెస్, కొన్ని లాజికల్గా డిస్కస్ చేసే ఉంటాయి. ఎవరైతే మెడిసిన్, సర్జరీ, గైనాప్స్ టిప్స్లకు వస్తుందో వాడు వీరుడు, సూర్యుడు. ఎస్పిఎం, డర్మటాలజీ, ఈ చెత్త సబ్జెక్టులకి డోంట్ వేస్ట్ యువర్ టైమ్ టు అటెండ్ కోచింగ్. ఐఎమ్ మై ఆనెస్ట్ అడ్వైస్. ఏముంటుందండి సోరియాసిస్ అంటే పొట్లు ఊడిపోతుంది, సోరియాసిస్. ఆస్పిట్ సైన్ ఉంటుంది, ఆ వచ్చే ప్లాక్ కింద బ్లీడ్ ఉంటుంది. అది ఒకళ్ళు వచ్చి ఢిల్లీ నుంచి వచ్చి చెప్పిపోవాలన్నా అవసరం లేదు, అట్నే పడ సక్తే అయినా. సో అనదర్ థింగ్, మొత్తం డర్మటాలజీ మీకు ఇచ్చే నోట్స్లో డర్మటాలజీ కరెక్ట్గా 28 పేజీలు ఉంటుంది అంతే. 28 పేజీలు ఎంతసేపట్లో చదువుతారు? న్యూస్ పేపర్ చదివినట్టు చదివేయచ్చు. ఒక్క రోజు కంటే ఎక్కువ స్పెండ్ చేయొద్దు డర్మటాలజీ మీద. హాఫ్ డే గట్టిగా చెప్తే ఓకే. దెర్ ఆర్ అబౌట్ 12 hours ఆఫ్ వీడియో ఓన్లీ ఆన్ డర్మటాలజీ, కవరింగ్ దోస్ 23 pages ఇన్ ది స్కోర్ లెర్నింగ్ యాప్. మస్తు అందులోంచే వస్తాయి క్వశ్చన్. ఎనస్థీషియా అది సబ్జెక్ట్ అయినా చదవడానికి, లిగ్నోకెయిన్, కొన్ని లోకల్ ఎనస్థెటిక్స్, ప్రైలోకెయిన్, దేంట్లో మెథమోగ్లోబినీమియా వస్తుంది, లోకల్ ఎనస్థెటిక్ ఎట్లా పనిచేస్తాయి. ఇంకోటి ఏమిటంటే మజిల్ రిలాక్సెంట్, నాన్ డిపోలరైజింగ్, డిపోలరైజింగ్. నెక్స్ట్ ఎనస్థెటిక్స్, ఇన్హలేషనల్, ఇంట్రావినస్ ఎనస్థెటిక్స్. ఇంకా కొంచెం వెంటిలేటర్ సెట్టింగ్స్, పీప్ అంటే ఏంటి, పోప్ అంటే ఏంటి. ఎంత 1 day, అంతకంటే ఇట్ డజంట్ డిజర్వ్ యువర్ టీయర్స్. ఎవరైతే లాస్ట్లో అరే నీకు ఆర్థోపెడిక్స్ ఎంత టైం పడుతుంది రివిజన్కి, ఎంతరా 12 గంటలు చాలు అన్నాడు అనుకోండి, వాడు సీట్ కొడుతుడు, వాడికి సీట్ వస్తుంది. ఎవరైతే అరే నా షెడ్యూల్ చూస్తాను రా, 8 days పెట్టుకున్నారా ఆర్థోపెడిక్స్ కనడానికి, అయిపోయేవాడు అక్కడనే గాన్, గేమ్ ఈజ్ ఓవర్. హీ లాస్ట్ ద గేమ్ ఆల్రెడీ. యూ డోంట్ రీడ్ ఆర్థోపెడిక్స్ ఫర్ నీట్ పీజీ టు ట్రీట్ ఫ్రాక్చర్స్. Can you treat fractures by reading 8 days, 10 days, even 2 months also? No. Then why are we reading? To know around 30 most common topics in orthopedics, to answer 10 most common questions asked in NEET PG. అర్థమైందా? మీకు ఎప్పుడైనా ఫార్మకాలజీ, పెథాలజీ, జనరల్ మెడిసిన్, సర్జరీ, గైనాప్స్ ఇవే తోడొస్తాయి. మీరు రేపు డర్మటాలజిస్ట్ కానివ్వండి, సైకియాట్రిస్ట్ కానీ ఏదైనా కూడా ఇవి కామన్. అర్థమైందా? ఈ ఎస్పిఎం, మైక్రోబయాలజీ ఇవన్నీ ఉన్నాయి చూసారా, అవన్నీ ఏంటి, పెళ్ళికి కావాల్సిన పాండిత్యం అంటారు కదా. ఒక 2 కర్ణాటక సంగీత పాట ఈ మధ్య ఎవరు పాడతలేదు పెళ్లి చూపుల్లో, పాడిపిస్తున్నారు అబ్బాయి చేత. సో ఏదో కొంచెం అంటే పెళ్లి కోసమని ఒక 10 కిలోలు బరువు తగ్గుతాం కదా, పెళ్ళైన తర్వాత 30 కిలోలు పెరుగుతాం, అది వేరు రైట్. వెన్ ఇట్ ఈస్ ఏ ఇర్రివర్సిబుల్ రియాక్షన్ వి కీప్ గ్రోయింగ్ వెయిట్. అట్లా షార్ట్ క్విక్ ప్రిపరేషన్ లాగా ఉండాలి. అర్థమైందా? డోంట్ నెగ్లెక్ట్ యువర్ ఇంటర్న్షిప్. బికాజ్ ఇంత చదివి ఇంటనకాల వచ్చిన మలేరియా, కలరా, టైఫాయిడ్ కూడా ట్రీట్ చేయడం రాకుంటే ఎందుకండి చదువు అవసరమా? సో కాబట్టి ఏం చేయాలి మీరు, కవి తిక్కన ఖడ్గ తిక్కన టైప్లా పోయి నాకు 30 డ్రగ్ల లిస్ట్ పంపిస్తా, ఒకసారి మనము ఆన్లైన్లో రివిజన్ చేద్దాం. ఆ 30 మందులు ఎప్పుడెప్పుడు వాడాలి, ఎట్లా వాడాలి అనేది. అంతే, ఆ 30 మందులు చదవాలి, పోవాలి, పట్టుకొని రాసి పడేస్తుండాలి ప్రిస్క్రిప్షన్. అర్థమైందా? ఓన్లీ టీబీ మందులు రాసే ముందు కొంచెం ఎల్ఎఫ్టీ చూసుకోవాలి, ఏస్ ఇన్హిబిటార్లను, ఏఆర్బీలు ఇచ్చే ముందర కొంచెం క్రియాటిన్ చూసుకోవాలి. అట్లనే పీడలెడిమా వస్తే కాల్షియం ఛానల్ బ్లాకర్లు బంద్ చేయాలి. ఇట్లాంటి కొన్ని ఉంటాయి. అర్థమైందా? సో అవి కొంచెం నేర్చేసుకుని పేషెంట్లతో ఎక్కువసేపు మాట్లాడితే యు లెర్న్. బట్ ఈ 1200 పేజీలని లాస్ట్ మూమెంట్ బిఫోర్ ఎంట్రన్స్ ఎవ్రీ 1 వీక్కి మీరు ఈ 1200 పేజీలు రివైజ్ చేయగలిగితే మీకు సీట్ వస్తుందప్ప. సింపుల్, రైట్? అలా కాకుండా అన్ని విలియమ్స్ పెద్ద పెద్ద బుక్కులు చదవాలి, వ్యాస్ట్గా చదవాలి, డీప్గా ఉండాలి నాలెడ్జ్. బేసిక్స్ ఏం బేసిక్స్ లేదు, తొక్కలేదు, ఏం లేదు. ఈజీ బేసిక్స్ ఏముంటుందండి? ఆల్ఫా వేవ్స్ ఏంటి, బీటా వేవ్స్ ఏంటి, థీటా వేవ్స్ ఏంటి, డెల్టా వేవ్స్ ఏంటి తెలుసుకోవడం వరకే. తెలియకపోతే సిగ్గుపడక్కర్లేదు, ఎందుకు ఇప్పుడు తెలుసుకోవచ్చు. Please don't feel guilt. Another common myth during entrance preparation is people think it's not good in that subject range. We know that you are not good in any subject, doesn't matter. Are you prepared now to become good with what is expected in for the tomorrow's exam? That should be your goal. All right, so let's meet next week, doctor. Look forward. Yeah, thank you. వాళ్ళందరికి షేర్ చేశారా మన గ్రూప్ లింక్? కొంచెం మీ 2018 బ్యాచ్ వాళ్ళకి చెప్పండి అండి, మీ దోస్తులకి. మీ సిఆర్ఏ అట్లెట్లు ఇస్తారు నెంబర్లు? మేము మా ఊళ్ళో ఇవ్వమంటే అన్ని ఎక్కడ పడితే ఇంటర్నెట్ అంతా ఉన్నాయి నెంబర్లు. అవి హృషికేశ కనీసం ఇన్ఫర్మేషన్ చెప్పు, క్లాస్మేట్లకి చెప్పిండా ఉందని? చెప్పాడా? అంతేలే, అంటే రైట్ మా, గుడ్ లక్. Next week we will take up ECG in the first half lo. Tell your friends.
Sandeep Dura, artist of computer, desktop computer.
దీపం అమ్మా అమ్మా, హలో, వాట్సాప్ అయిపోయిందా? అచ్చా, అంటే ఇప్పుడు ఎట్లా ఒక నంబర్ కొట్టంగానే మొదలు పెట్టుకోవచ్చా? ఓకే, అంటే ఇదివరకు మీకు బ్యాన్ చేసేవాళ్ళు కదా పెట్టంగానే, అది లేదా? అట్లా మనకి బ్యాన్ చేసేవాళ్ళు కదా, బ్లాక్ చేసేవాడు కదా. ఎందుకు ఇప్పుడు వీళ్ళది బ్లాక్ కాదు కదా? ఓకే, గుడ్ గుడ్. సో ఇప్పుడు అన్నీ వచ్చేస్తున్నాయి. ఓకే, సూపర్. మరి ఇంకేం? పేషెంట్ డాక్టర్ అని అక్కడ అడుగుతుంది. నేను డాక్టర్ పెట్టుకున్నా కూడా వెనక నుంచి యాక్టివేషన్ ఇవ్వకపోతే డాక్టర్ కాదు కదా. వెళ్ళకూడదు, మీరే కంట్రోల్ చేయాలి. అదే మరి నో, వాడు పేషెంట్ డాక్టర్ని పెట్టుకొని ఏమైంది, మనం డాక్టర్గా మారుద్దాము అంతే. అంటే మనం బ్యాక్ ఎండ్లో ప్రతివాడు వచ్చిన అది ఆటోమేటిక్గా యాక్టివేట్ చేసుకుంటుంది. అక్కడ కొంచెం దాన్ని ఆపండి. మళ్ళీ అది ఆపితే ఇంకా ఎక్కడైనా మనం యాక్టివేట్ చేసినప్పుడు కూడా కాదా? అట్లా ఓకే ఓకే చెప్దాం. అంటే నేను అనుకోవడం మీరు చేయగలరేమో అని, ఎందుకంటే ఒక స్టేటస్ రిసీవ్ చేసుకుని వాటి రిక్వెస్ట్ లాగా. ఒకసారి చూడలేదు నేను, మళ్ళీ ఆయన అడిగి ఆయన నో అని ఎందుకు. నేను ఎవరిని అడగలుగుతాను, ఎవరిని ఇప్పుడు అడిగితే ముందే 2 दिन लगेगा అంటాడు. ఏమి చెప్పకపోతేనేమో టెన్షన్ పడతాడు. ఏం చెప్పట్లేదు ఏంటి సార్, ముందే భూల్ గయా అంటాడు. అది కష్టంగా ఉండదు మా మనసుతో, ఇమోషనల్. సో మీ లెవెల్లో కొంచెం చేసి కొంచెం చెక్ చేయండి అన్నమాట. అంటే మీరు యాక్టివేట్ చేస్తే అయిపోతుంది సార్. వెరీ గుడ్. అయితే మరి మీకు అయిపోవాలని చెప్పండి, నేను ఒకసారి టెస్ట్ చేసి నేను షాంకి చెప్పి నేను అర్జెంట్గా ఒక గిఫ్ట్ పంపించేది. చిన్న గిఫ్ట్. అవును, శ్యాము భవాని హస్బెండ్ వైఫ్. 5 లక్షలు. అవునవును, ఈ విషయం ఒకటే మంచి ఆయన, వెరీ నైస్ పర్సన్. సో దిస్ ఈస్ హైలైట్. అసలు వాట్సాప్ నుంచి కావడం అనేది హైలైట్, వాళ్ళ హెల్ప్ లైన్ నెంబర్. అంటే అన్ని ఇప్పుడు దీంట్లో ఐడెంటికల్ ఫీల్డ్స్ అందులో కూడా. ఓకే సార్, అది మళ్ళీ టెస్ట్ చేద్దాం నేను బగ్ వస్తుంది. అట్లా తప్పకుండా. షూర్. ఓకే.
డిసప్పాయింట్ అయ్యాను. 20 మంది వస్తారా?
నెక్స్ట్ వీక్ వద్దామా వద్దా?
డబ్బులు కట్టుకుంటా.
డబ్బులు వస్తే
కాసు కొత్తగా 2000 అన్న పే చేసుకుని రావాలి.
ముందరే పే చేస్తే
అప్పుడు అంటే కన్ఫామ్ తెలియదు కదా అంటున్నాను. ముందే 10 మంది కడితే 10 మంది కట్టాను. 10 మంది కడితే అమౌంట్
మనకి వెన్యూ ఫ్రీ అయిపోతుంది.